Eliminating opioid use after mini-laparoscopic gynecologic surgery. Effectiveness of a multimodal pain management approach adopted into clinical practice. In 2014, a Chicago-based surgeon, fresh out of MIGS fellowship, performed his first mini-laparoscopic hysterectomy at a small community-based hospital located in Chicago, Illinois. The hysterectomy was performed using a 3mm endoscope, two 2.9mm percutaneous graspers, and a 5mm vessel sealing device. Postoperatively, the patient did not require any opioids during her postoperative recovery and stopped all pain medications 4 days after surgery. Pain level and postoperative opioid requirements varied, however, in subsequent patients undergoing mini-laparoscopic hysterectomy. Thus began a pursuit to identify an effective pain medication regimen able to consistently eliminate postoperative opioid use in all patients undergoing mini-laparoscopic surgery. In 2012, the American Society of Anesthesiologists released an update on the practice guidelines for acute pain management in the perioperative setting. Included in this update report were guidelines on perioperative pain management and recommendations on multimodal techniques for pain management. In 2015, a pain medication regimen derived from these recommendations were incorporated into clinical practice. This multimodal pain management approach combined mini-laparoscopic instrumentation with a multimodal pain medication regimen consisting of oral gabapentin, celecoxib, acetaminophen, and ropivacaine local anesthesia. The objective of this video is to identify an effective non-opioid multimodal pain medication regimen in women undergoing mini-laparoscopic gynecologic surgery, defined in this study as using laparoscopic instrument ports with an inner diameter of 5mm or less. A 1-year quality improvement single institution study was conducted on patients undergoing mini-laparoscopic gynecologic surgery, defined in this study as using 3 instrument ports with an inner diameter of 5mm or less. Patients undergoing mini-laparoscopic gynecologic surgery were prescribed a perioperative multimodal pain regimen consisting of ropivacaine local anesthesia, acetaminophen, ketorolac IV, celecoxib, and gabapentin. Please note that use of gabapentin in this study is off-label and it is indicated for treatment of postherpetic neuralgia and seizures. The multimodal pain medication regimen is given as follows. Preoperatively, on the evening prior to surgery, patients were given gabapentin 300 mg by mouth. The morning of surgery, acetaminophen 1,000 mg and gabapentin 300 mg PO was given. Intraoperatively, 0.5% ropivacaine diluted in 1:1 ratio with injectable saline was injected to the skin prior to and after skin incisions. Postoperatively, patients were continued on gabapentin, acetaminophen, and ketorolac 30 mg IV Q6 hours, then switched to oral celecoxib 200 mg every 12 hours for 6 days. Postoperatively, the number of opioid doses given to patients in 3 phases of the postoperative period were evaluated. Phase 1 consisted of opioid use on the day of surgery after leaving the PACU. Phase 2 consisted of monitoring patients' opioid use on hospital day 1 of surgery. Phase 3 consisted of opioid use monitoring after discharge. Between May 2017 and May 2018, 38 patients underwent surgery using 3 laparoscopic instrument ports measuring 5mm or less in diameter. None of the procedures were converted to laparotomy, and there were no intraoperative complications. 1 patient had an NSAID allergy and was excluded from the study. 3 cases required a 2 to 3 centimeter mini laparotomy incision for removal of very large fibroids. These patients were also excluded from the study. 34 cases were included in this study, which consisted of 8 mini-laparoscopic ovarian cystectomy and endometriosis management, 21 mini-laparoscopic hysterectomies, and 5 mini-laparoscopic myomectomies. In the 8 patients who underwent mini-laparoscopic ovarian cystectomies, none of the patients received opioids after the PACU. Of the 5 mini-laparoscopic myomectomies who did not have a mini-laparotomy, none of the patients received opioids after the PACU. Of the 21 mini-laparoscopic hysterectomies, 2 patients received opioids after the PACU. 1 patient received a single dose of opioids on hospital day 1. Uterine weight for that case was 252 grams. The other patient was on opioids prior to surgery, received opioids throughout hospitalization and after discharge. 19 patients did not receive opioids. For the 8 mini-laparoscopic myomectomy cases, 3 of the cases required a mini-laparotomy for fibroid removal. Of the 3, 2 patients did not require opioids, and 1 patient required opioids during and after hospitalization. Of the 5 other cases that did not require opioids, 1 case had fibroid removed through the 5-millimeter umbilical port, and the other 4 cases had fibroids removed from the posterior cul-de-sac by means of an endocatch bag. In summary, 34 patients used the pain medication regimen. 1 patient was excluded due to an NSAID allergy. 32 patients did not require opioids after surgery, and 2 patients did require opioids after surgery. Of the 2 cases, 1 of the patients was already taking opioids prior to surgery. Potential risk factors for opioid use after surgery is history of opioid use prior to surgery and surgeries performed on very large uteri. When combined with mini-laparoscopy, a non-opioid multimodal pain medication regimen consisting of ropivacaine local anesthesia and around-the-clock acetaminophen, celecoxib, and gabapentin is able to effectively eliminate the need for postoperative opioid use in patients undergoing laparoscopic gynecologic surgery.